Medicine X 2016. I'm your host, Louise Shaper. We are here at the Ignite stage, where the presenters only get 5 minutes to tell you their story. So up next, speaking on the topic of how to use open healthcare data to empower patients, please welcome to the stage Fred Trotter. Welcome, Fred.
Thank you. I'd like to ask the question, can we stain doctors? So a long time ago, I became famous for releasing healthcare data, and at the time I said I would like help creating a system of ranking doctors that doctors found fair and patients found useful. And that was, I think, something to the tune of 5 or 6 years ago, and I had this notion that I would get that done that year, and I'm still trying to do that. So I've been expanding what's available in open data about doctors and fighting with the government or cooperating with the government, depending on the day, to make sure that there's more data from Medicare or Medicaid to understand how doctors work. And that has been very successful. DocGraph has spun out a company called CareSet, which is the first Medicare data vendor, and allowed me at DocGraph to focus more on what I feel like is my original mission, which is to try to make open data about doctors into something that patients can actually make use of. Quick survey, and I apologize for the video people who are not going to be able to see this. How many of you have used the healthcare system, or your major family members have used the healthcare system in the last 5 years? Please raise your hand. Almost everybody. How many of you used Hospital Compare or Doc Compare from HHS to actually look and see information about the quality of the physicians or hospitals that you work with? Raise your hand. All right. The fact that the UK version counts and any other country counts, absolutely. I think there's under 5% of the people in the room who are the technorati of healthcare have actually done that. So right now we're in a situation, we need to be realistic. We are a biased sample. We are, Medicine X are the people who are the elite, and even we are not using this. It's not working. And the problem is actually not here either. Stanford is an amazing hospital. It's a top 10% hospital. These are, all of us are coming from the parts of the healthcare system that are motivated to do things right. And the bottom 10% is where the real problems are. And we need to be realistic. Consumers cannot engage. So we wonder why consumers have not engaged. They're not going to engage. So there's not going to be a moment when consumers are going to suddenly become interested in data. They're just not. So I have been trying to figure out what might work. What I think might work is things like PageRank. So at the very beginning of Google's success, they had an algorithm which allowed essentially pages to vote for each other for importance, and allowed for them to algorithmically detect, by allowing one page to vote for another page, which pages were important. I think I'd like to try to reverse that notion. I'd like to find a way for problems inside the healthcare system to kind of expand out, and rather than finding out where your votes automatically improve your ranking, where if you're doing a really terrible job, they lower your ranking. So the bottom 10% of hospitals have things like multiple Medicare inspections, and you should read them. They're available from the healthcare journalist website. Hospitalinspections.org, I think, is the website. And when you read these things, really, truly, if you've had a hospital that has had more than one Medicare inspection and horrible patient safety risks, these are really terrible hospitals. The question we should all be asking is, how do these hospitals stay in business? And the answer is doctors refer to them. So what I want to do is I want to say, if you're a primary care provider who refers to a cardiologist, who refers to a hospital with a terrible central line infection rate, that should be a problem for you, right? So that's that kind of graph-based algorithm where we use nodes on one side of the network to figure out what's going on the other side of the network. If we reverse them and we start to use them in reverse, in a stained manner, so that the terrible hospital stains the cardiologist, and the terrible cardiologist then, who is otherwise okay, except that he's willing to work with a hospital, very frequently for financial reasons, that's doing a bad job on heart patient care, that fact then becomes a problem for the primary care physician who refers to him. So we can't, if we're going to try to work with coordinated care and things like this, I'd like to be able to start moving things in that direction. As I looked into how to do this, I can report to you that it's extraordinarily difficult. One of the problems is some of the worst hospitals in the country very frequently are mental health facilities, and the reason they're terrible is because we don't pay enough for them to exist. So Or there's many cases where the most terrible hospitals in the country are the only regional hospitals for 100 miles. And they're in really small towns, and they can't get any competent executives to come out and do it. So one of the Medicare inspection reports that was of one of the worst hospitals said they're dinging them because they didn't have a CEO. Well, and then, of course, inside there, you find out that because they didn't have a CEO, they had some kind of infection or some kind of huge patient safety event, and they don't have any kind of oversight at all. So I'm experimenting with this. I don't want to pretend like I figured this out, but if you're interested in these kinds of ideas, the notion that we can use the structure of healthcare and open data to create systems where doctors are ranked based on what other parties are doing, I think will accelerate the part of healthcare that works right now, which is the reason why healthcare in the United States is good in general, is because our doctors keep each other accountable. The problem is that sometimes they act like a union, and by trying to focus on very specific details about who is referring to who does a bad job, I think we can kind of fix those things. Anyways, that's the idea. I want to see what you guys think about it. Find me after if you think that's interesting. Bye.
I'm blocking you off here because I thought we've got some time. Let's have some questions. So anyone got any questions for Fred about his idea? Do you think it's a good idea? Let the audience, let the video camera know that the crowd went wild and went, oh my God, that is like the best idea ever. They did, didn't they, Fred? Yeah.
No, they didn't. But thank you for that. I really appreciate the sentiment.
All right, then.
She actually had a question.
Brilliant. Yes, Jennifer.
So I'm wondering if your idea not only incorporates the notion that patients could have access to this data, but also doctors, because I know that when I refer to people, you know, I have very few people who I actually trust, who I really know, but it would be great to have some data as a provider about other providers that you refer to. So I wonder if the provider and the patient are sort of worked into the way you conceptualize this.
So absolutely. I mean, one of the things that we see when we talk about other ranking systems is very few people actually have, say, a Consumer Reports account, but we still see that the industries who manufacture things really respond to what happens inside Consumer Reports. So we don't need a lot of people to pay attention. We can get by with a very, very few consumers, but we do need at least some consumers to pay attention. So that's critical. So when I said that patients are not engaged, that is a huge problem. We certainly can't design any systems that rely on 80% of patients to be evaluating their physicians or hospitals. That will never happen. And then the other side about physicians, when you have that conversation with, say, Dr. Bob Smith, who's a primary care, and Dr. Susan's the cardiologist, and Dr. Bob needs to be in a position to say, my score is being hit because of you, Susan. And also what you need to do is maybe stop referring to a hospital or go talk to the CEO of the hospital that you're working with to figure out what they're going to do next year about their central line infection rates. They have to be able to treat the scoring system as a kind of checklist, right? So that one doctor can say, I know, you know, you're my cardiologist and I need you to start doing these things. And if you don't, I'm going to have to fire you as my cardiologist because your score affects mine. So I think that's the way it should work, but to be frank, I have really no idea, and these are all totally experimental things.
Isn't that powerful? Someone's on stage with a microphone saying, to be honest, I'm really not sure. We're going to get started here, but you're looking for input. That's really good, Fred. So I have another question, and someone who's actually going, I think.
So I really thought I was going to be able to get off the stage.
Yeah. No, I'm filling in time here, mate. So. Yeah. Okay, right. We've got another question for you. Please. You're cool? There we go.
Sorry, Fred, but you know I'm drinking the Kool-Aid here. So as an e-patient, e-mom, e-daughter, how do I sign up? How do I get started?
You know, I have thought about going to the Society of Participatory Medicine, which I think is kind of the hub for the watering hole for e-patients online, and just asking, because, you know, as you see, I want to be honest, I don't really know how this should work. But I also know that any system that doesn't involve the patients, even for that 1% or 5%, is doomed to fail. So what I have thought about doing is going to the Society for Participatory Medicine and just saying, I want to find 1,000 patients who are willing to do some really crazy shit, and try stuff and possibly go to a hospital they've never gone to before to, you know, do some patient shopping type stuff. I really don't know what's going to work, but I do know that unless you involve e-patients and patients in general in a systematic way, and unless it is a cornerstone of the strategy, it's doomed to fail. So again, totally confused about what we should be doing here, but I'm sure about a few things, and I think having that e-patient as a strategic pillar is one of the things I'm sure about.
Well done, Fred. It's It's good to hear an American swear on stage. You guys are always so polite, and we swear a little bit more in Australia. Or you guys say curse, don't you? So it's really not cool to do that, and I'm always really worried I'm going to. So I'm pleased you said the S word. That's great.
Did I?
Yeah, you did. You said, we're going to do some crazy shit, and I want you to sign up for it. So there you go. I'll make you feel better that you swore.
Thank you. I wasn't aware of that.
It's all right. It's not
It's what
HBO
makes me a
language,
compelling
so
speaker,
we're all
I
right,
think, is that I'm just talking. Go ahead.
All right, we have one more question
One
for
more
you.
question, okay.
Okay, James?
I assume you've looked a lot at this, and your impression is that the sites that are out there now that recommend doctors by social voting aren't very good and not reliable.
So actually, I think some of them are marvelous and they're doing good things. I think this needs to be something that is available to those sites as a kind of resource. So I'm actually planning on, and again, I really truly have no idea, but I think the way it should work is it's an algorithm that I publish, and I publish the underlying data needed to run the algorithm, and I allow any doctor ranking site to do this. I don't want this to become something that's a competitive advantage so that, this really good rankingwebsite.com has this. What I think it needs to be, because what I want is for the ranking system to be something that doctors respond to. And if it's only on US News, or it's only on ProPublica, or it's only on, they just don't care. But if they realize that they're being dinged on every single consumer ranking site, and that every time they go anywhere, they're either high on the list or low on the list, depending on whether or not they're working with other good providers, I think that's the way it should work. So, one of my basic tenets with DocGraph has been that I release open data, I release stuff of value in the world, and try to encourage people to work together. So I think this is the kind of thing that consumer ranking websites should be working together on rather than against each other.